Cameron.
Thank you. It's a pleasure to serve under your chairmanship, Mr Wilson, and I'd like to thank and congratulate the Honourable Member for Hailstone and Rowley Regis for bringing this really important and very timely debate to Westminster Hall today. Although the report pertains to NHS England, we very much welcome the report. It's an opportunity to share best practice recommendations right across the UK. I'd also like to declare a particular interest in terms of having worked in mental health for 20 years prior to coming to the House as a psychologist, and so I'm particularly glad that this report has been produced. I think it's an excellent report, and I would commend the work of those involved. It's detailed, it's thorough, and importantly, it's based on inclusivity and service users' views. It addresses key issues of prevention, access and parity. In terms of prevention, we know that half of mental health issues are established by the age of 14 and 3/4 by the age of 24. So it's clear that there requires to be a new focus on young people. Effective interventions designed for this age group via CAMS. More widely, I wonder if we should also be looking at mental health awareness training for teachers, picking up on early warning signs so that we can refer on. And I wonder if mental well-being might be considered as part of the curriculum, whereby young people can develop positive adaptive coping strategies, which is really key to prevention of onset of mental illness. Obviously, we're dealing with a young generation, so use of technology, apps, things that I'm not particularly familiar with, but have to get up to speed. But modalities that young people like and use are going to be really important, and we require evidence-based interventions for self-harm in particular, eating and conduct disorders, depression and anxiety, which are common problems within the younger age group. In terms of crisis teams, I welcome the fact that this is to be locally based 24/7. I wonder if we can have some more detail. Will it involve specialist clinicians or nurses who are on call, or doctors on call trained in working with young people in each area? And again, more widely, in order that people will present, should we be having more public awareness health campaigns to reduce stigma? In terms of mental health care, this requires to be targeted across the lifespan. Younger people in CAMS, adults and older adults. The report establishes that 40% of older adults in care homes are affected by depression. Yet, I read very little information about services provided or required for older adults who may have comorbid dementia, physical frailty, have suffered stroke or adjustment problems or loss. And it suggests that this area needs some more work and detail. Access to psychological therapies in the community, in hospital and in residential care appear to be key, and it's likely to require experts in psychological therapy in older adults because people will be working with very complex presentations. I welcome the Taskforce report recommendation for integrated approach, looking at housing, employment, social needs and physical health. This suggests to me an integrated and holistic assessment approach in mental health, but also one that will be required in physical health settings. It's a formulation-driven approach, an understanding of precipitants, problems and exacerbating factors, but also an understanding of protective factors. All of these factors need to be targeted and integrated into treatment in order to evidence improvement. So fundamentally, we're speaking about a biopsychosocial approach, which I would suggest is a change in assessment procedures across the system. We will have to evidence how this will happen, how it will be implemented right across both mental health care and physical health care, but I think that it links very well to the integration agenda of health and social care. I would caution that although obtaining work is a very positive step in reducing depression for many people, pushing someone into work who is acutely unwell will set them back invariably. So this is about clinical judgment and timing. One of the major differences since I started work in the NHS over 20 years ago to the current time is that we now have waiting time initiatives in Scotland and across the UK. This is significant. It challenges services to focus, and monitoring leads to improvement in standards, but it must have an ongoing and underlying investment. I welcome the recommendation of crisis care being provided 24/7. Specialists will require, however, to be trained to work with those individuals who have comorbid substance abuse and mental illness problems. All too often, people are turned away because they're intoxicated at hospital when they present. I understand that it's difficult to assess people properly in this condition, but unfortunately, research indicates that this may be when they are at highest risk of suicidal behaviour and at their most impulsive. I welcome access to psychological therapy for new mothers in particular. 1 in 5 have depression, and that impacts on the self, family and the baby. I would also suggest a requirement to extend counselling to those who have suffered miscarriage or stillbirth and who experience great trauma in this regard. In terms of the recommendation about specialist GPs, I'm unsure exactly of the fit of this from my reading at this stage. Is it treatment through minimal interventions, or is it assessment by GPs? Is it about specialist nursing staff in GP surgeries who could perhaps engage in treatment? Because my concern is really around about the cost effectiveness of GPs engaging in therapeutic work. But I think that it's a welcome idea in terms of training and assessment at a primary care level. The report highlights that 9 out of 10 people in prison have mental health problems, drug or alcohol misuse. It doesn't clarify implementation or recommendations in criminal justice, however. Again, this is going to require cross-party, cross-government and cross-party agreement in terms of how to implement right across the country. Is it about access to psychology in prisons? Again, it needs a bit more thought and detail and integration. I think I'm going to have to sum up because I'm running out of a bit of time here, and I want the Minister to be able to respond. But basically, the few things I want to say just to finish up are I'm very pleased to see what I believe to be one of the key issues which is going to transform mental health care included. That's technology that can transform mental health service, use of Skype, email, online treatment packages, increasing access and links to therapists, and improving access for rural communities. In terms of data collection, I think that it's excellent. We need to have that. We need to evidence outcomes and waiting times. But I would appeal for balance. Drowning mental health staff in paperwork is not the answer. It reduces time for clinical work, time with patients, and we don't want it to become a tick box exercise. So in conclusion, there's much to welcome. There's much to do. We need more strategy around integration plans, more detail in terms of older adults, forensic criminal justice, and I wasn't able to touch on learning disability today, but I think, again, another area. We don't want a postcode lottery, so it's important to look at local commissioning and to share best practice and ensure high quality mental health right across the UK.
Luciana Burgess.